Welcome to this medicine masterclass in which we will be discussing how to perform a cardiovascular examination. Start by washing your hands, introducing your role and confirming the patient's details. Explain the examination and gain consent, offer a chaperone and ensure the patient is adequately exposed and positioned semi-recumbent at 45 degrees. Explain to the patient that you'd like to make some general observations about the room and around the patient. Look for any medical equipment, including oxygen delivery devices, ECG leads, the presence of any medications, catheters or cannulas. Look for any vital sign charts or fluid balance charts and inspect those. Determine whether or not the patient has any pillows with them. They may be using these to prop themselves up, particularly if they have heart failure and fluid is accumulating in their lungs, causing symptoms of orthopnea and paroxysmal nocturnal dyspnea. Examine for any mobility aids such as walking sticks or wheelchairs, which may give you an idea about the baseline function of the patient, which would help you manage the patient. And then observe the patient. Do they appear edematous? Edema can result from congestive heart disease, from liver or renal disease. Do they appear breathless or cyanosed? Are there any visible scars? Do they appear anemic? Is there a malar flush, a redness of the upper cheeks? Are they obese or do they appear syndromic? In particular, Marfan's syndrome is associated with aortic regurgitation. And then start by examining the patient's hands. Look for signs of clubbing. Finger clubbing involves uniform soft tissue swelling of the terminal phalanx or phalanges of the digits, with a subsequent loss of the normal angle between the nail and the nail bed. Finger clubbing is associated with chronic diseases. In the context of cardiovascular disease, this would include subacute endocarditis, cyanotic congenital heart disease, or rarely an atrial myxoma. Also look for other signs such as splinter hemorrhages. These are small longitudinal red-brown hemorrhages under the nail that look like a wood splinter. And these can be caused by trauma, infective endocarditis, sepsis, vasculitides, as well as psoriasis. Inspect for any signs of tar staining. Cigarette smoking is a significant risk factor for cardiovascular disease. Inspect for xanthelasma and xanthomata. Xanthelasma are sharply demarcated yellowish collections of cholesterol underneath the skin and can also be seen around the eyes as well. And when these become large and nodular, these are known as xanthomas. Inspect for signs of endocarditis, looking for Osler's nodes and Janeway lesions. Osler's nodes, typically found at the tips of the fingers or toes, are red-purple, slightly raised tender lumps, often with a pale centre. Janeway lesions are non-tender hemorrhagic lesions that occur over the thenar and hyperthenar eminences of the palms and can also be seen on the soles. Inspect the shape of the hands and the digits. If there's presence of arachnodactyly, that's where the fingers or toes are abnormally long and slender in comparison to the palm and the arch of the foot, this is a feature of Marfan's syndrome, and this is associated with mitral aortic valve disease. Polydactyly, where there's an extra digit, can be associated with conditions that affect the heart. For example, Holt-Oram syndrome results in an extra digit and an atrial septal defect. Inspect for a tremor, which may be seen as a result of thyrotoxicosis. Inspect the capillary refill time by pressing over the digit for 5 seconds and observing how quickly the colour returns. Normal is less than 2 seconds. If the capillary refill time is prolonged, that may suggest hypovolemia or poor peripheral circulation. Examine the temperature of the hands. Cool hands may suggest a poor peripheral circulation as a result of congestive heart failure. Move on to examine the pulse. Palpate the radial pulse. The radial artery arises from the bifurcation of the brachial artery in the antecubital fossa. Use the tips of your index and middle fingers. Measure the rate and regularity. Measure for 30 seconds and multiply this rate by 2 to calculate the pulse rate per minute. If the pulse is found to be irregular, calculate a range. There are several types of pulses. A bradycardic pulse, less than 60 beats per minute, can be seen in young, healthy or athletic individuals, but can also be as a consequence of drugs such as beta blockers, digoxin, or sinoatrial disease, or endocrinopathies such as hypothyroidism, as well as electrolyte disturbance. Tachycardic pulse, more than 100 beats per minute, can be physiological as a result of exercise or pain, or can be due to fever, anemia, bleeding, thyrotoxicosis, or drugs such as amphetamines, beta agonists, or electrolyte disturbances. If the pulse is irregular, this may be as a result of atrial fibrillation or sinus arrhythmia, which would give rise to an irregular pulse, or may be due to premature ventricular complexes, which every so often would feel like an irregularity. Second-degree heart block with a variable response, both Morbitz type 1 and Morbitz type 2, also result in an irregular pulse, which is usually regularly irregular. The pulse may be slow rising and delayed, and this is known as pulsus parvus, and this is associated with aortic stenosis. A collapsing pulse or a water hammer pulse may be associated with aortic regurgitation or patent ductus arteriosus. Pulsus alternans is where, when you're feeling the beat, when you're palpating the pulse, there is beat-to-beat variation in the strength of the pulse volume, and this is seen in advanced heart failure. Essentially, in heart failure, there is poor contraction. This increases the end diastolic volume. The increased end diastolic volume increases the stretch on the myocardium. That, through the Frank-Starling mechanism, increases the force of that subsequent contraction, and then that cycle repeats. And this ECG demonstrates electrical alternans, where you can see a tall QRS, a short QRS, and that cycle repeats. You may note pulsus bisferiens, a biphasic pulse in which the aortic waveform has two peaks in the cardiac cycle, and this can signify aortic valve disease. Both stenosis and regurgitant murmurs can result in pulsus bisferiens. A jerky pulse is classically seen in hypertrophic obstructive cardiomyopathy, and this is where the pressure wave is characterized by a rapid upstroke due to the vigorous contraction of a hypertrophic left ventricle, and then as the volume of the left ventricle decreases, there's a sudden obstruction to the left ventricular outflow tract, and that results in a jerky pulse. Once you've palpated the radial pulse on one side, move on to measure and feel both of the radial pulses on the left and the right to assess for radial delay, and then to assess the radial pulse on one side and the ipsilateral femoral pulse to determine whether there's a radiofemoral delay. Now, radial and radiofemoral delay describes a loss of synchronicity between the pulses. If there's radial or radiofemoral delay, this might be as a result of aortic coarctation, subclavian artery stenosis, which can be as a result of compression from a cervical rib, or aortic dissection. Now, a collapsing pulse is the fourth maneuver that you should aim to elicit. To do this, this is a pulse which rapidly increases and then subsequently collapses. Ask the patient if they have any pain in their right shoulder. Explain to them that you would like to raise their arm briskly above their head, and if you have consent to do this. Palpate the radial pulse with your right hand wrapped around the patient's wrist, and palpate the ipsilateral brachial pulse, which is found medial to the biceps brachii tendon, with your other hand, with your left hand, while supporting the patient's elbow. Raise the patient's arm quickly above their head and feel whether you can feel the pulse collapse from the radial towards the brachial pulse. And this can occur in some physiological states such as fever and pregnancy, but can also occur in aortic regurgitation and patent ductus arteriosus, as well as high output states such as anemia and AV fistulae. So having examined the right pulse on its own, then the radial, radiofemoral, and collapsing, the next thing to ascertain are the blood pressures. Request a systolic and diastolic blood pressure in both arms and legs, and also request a lying and standing blood pressure. If there's evidence of hypertension, then follow the NICE guidance and organise further investigations and management. The difference between the arms and legs should be negligible. It should not exceed more than 20 millimeters of mercury. Otherwise, this can suggest an underlying condition such as aortic dissection in the presence of a relevant history and signs. The lying and standing blood pressure equally should not be significantly different. If there is a difference of more than 15 millimeters of mercury, this suggests that there is orthostatic hypotension and the autonomic nervous system is not able to maintain the blood pressure when the patient is standing. Calculate the difference between the systolic and diastolic blood pressure. This is called the pulse pressure. A narrow pulse pressure, i.e. less than 25 millimeters of mercury, can be as a result of advanced aortic stenosis, congestive heart failure or tamponade, whereas a wide pulse pressure, i.e. more than 100 millimeters of mercury difference between the systolic and the diastolic blood pressures, can be as a result of aortic regurgitation or dissection. Now move on to examine the face. Ask the patient to lower the lower eyelid and assess the conjunctiva. If the conjunctiva is pale, i.e. there's a presence of conjunctival pallor, this could suggest underlying anemia. Inspect the eyes for corneal arcus. This is a hazy, opaque ring located around the periphery of the cornea. And in elderly patients, particularly over the age of 60, this can be physiological and benign, and this is known as senile corneal arcus. In younger patients, this may alert you to the possibility of hypercholesterolemia. Similarly, xanthelasma around the eyes are also associated with hypercholesterolemia. Offer to perform fundoscopy by, in particular, looking for diabetic retinopathy or hypertensive retinopathy in the context of cardiovascular disease. Diabetic retinopathy classically has 4 stages, stage 1 to 4. One is background, where you just develop microaneurysms and hemorrhages, as well as hard exudates. And stage 2 is pre-proliferative, where there's an ischemia developing as a result of the diabetes on the retina, and these are seen as cotton wool spots or a slight whitening of the retina. And this can also be seen in the context of hemorrhages and venous beading. This ischemia leads to stage 3 diabetic retinopathy, which is called proliferative diabetic retinopathy, where the retina responds with mitogenic factors to develop new vessels, and this can eventually lead to stage 4 maculopathy, resulting in decreased acuity. In diabetic patients on the fundoscopic examination, you may see an image such as this, which demonstrates panretinal photocoagulation, and this is a procedure used to burn parts of the retina to prevent the development of new vessels being formed. Fundoscopy for hypertensive retinopathy patients also has 4 classic grades according to the Keith, Wagner, Barker system. Grade 1 is where the high blood pressure in the retinal vessels increases the tortuosity of these vessels, and that increases their reflectiveness, and this is described as silver wiring. Grade 2, the thickened retinal arteries can press over the retinal veins, and this is known as AV nipping. Grade 3, where results in flame-shaped hemorrhages and cotton wool exudates. And finally, grade 4, advanced hypertensive retinopathic changes result in papilledema, where you'll have a blurred margin of the optic disc. The other things to inspect in the face are whether or not the patient has a malar flush. That's the plum red discoloration of the high cheeks associated with mitral stenosis. Inspect the oral cavity by looking at the lips as well as underneath the tongue for signs of cyanosis. And this is associated with hypoxemia, particularly seen in a right to left cardiac shunt. Inside, assess for a high arch palate. This is a feature of Marfan's associated with mitral and aortic valve prolapse. Inspect the teeth for dental hygiene, which can be a risk factor for endocarditis, and also have a look at the uvula, which can pulsate in advanced aortic regurgitation. Move on to examine the neck. Inspection of the neck is very important. There may be subtle scars associated with a carotid endarterectomy. This patient, demonstrated on the slide, has bilateral carotid endarterectomy scars. In the neutral position, the scar is subtle, but asking the patient to rotate and extend their neck, the scar is more visible. Examine the carotid pulse. First, auscultate to ensure there are no obvious bruits so that you don't risk dislodging atheromatous plaque, and feel and palpate a carotid pulse one at a time. The carotid pulse is located between the larynx and the anterior border of the sternocleidomastoid, and here assess for rate, character and volume, as well as the presence of any bruits or radiation of murmurs. Also in the neck, examine the patient's jugular venous pressure. The JVP provides a surrogate measure of central venous pressure, and that's because the internal jugular vein, which is what you're able to observe, connects directly to the right atrium without any intervening valves. And that means that a change in the right atrial pressure is reflected in the internal jugular vein, so raised right atrial pressure will result in distension of the internal jugular. Just remember that there are several ways to distinguish a JVP from the carotid. The JVP is readily occluded by digital pressure, whereas the carotid, it remains palpable. The JVP is lateral, found between the heads of the sternocleidomastoid, whereas the carotid is medial, found between the anterior border of the sternocleidomastoid and the larynx. The JVP is affected by inspiration, it decreases, whereas the carotid is not. The JVP has classically a biphasic waveform and the carotid has a monophasic waveform. JVP is affected by posture, it drops when the patient is sitting upright and erect, whereas the carotid is not affected by posture. The way to determine and examine the JVP is to ensure the patient's in a semi-recumbent position at 45 degrees, ask them to turn their head slightly towards the left and inspect the internal jugular vein and measure the vertical distance of the peak wave from the sternal angle, and it should not be more than 3 centimeters. An additional feature to assess the jugular venous pressure is called the hepatojugular reflux. In this, there is pressure applied over the liver, which results in increased cardiac return, and that causes a rise in the JVP. In healthy individuals, that rise should not persist for more than 1 or 2 cardiac cycles. The JVP should then fall back to before you accentuated it. If the JVP is sustained, that suggests that the right heart is unable to accommodate the increased venous return, and that may be as a result of right or left heart failure, restrictive cardiomyopathy, or constrictive pericarditis. The waveform itself, just to be aware of it, is a biphasic waveform, and the two phases are the A wave and the V wave. The A wave corresponds to atrial contraction and the V wave corresponds to atrial filling. The A wave is followed by an X descent and the V wave is followed by a Y descent. Just be aware that in the descent of the A wave there's also a flicker called the C wave, which results from the closure of tricuspid valve, which transiently increases the pressure in the right atrium. So looking at this as a waveform, you can see in atrial systole the A form. As the atria relaxes, you have the X and X prime descent interrupted by the C wave, the closure of the tricuspid valve, which is where ventricular systole begins, and then as the tricuspid valve is closed and blood is filling the atria, you can see the V wave. And then as the tricuspid valve opens, you have movement passively from the right atrium into the right ventricle, resulting in the Y descent. Things that would raise the JVP: fluid overload, right or left or congestive heart failure, pericardial effusions, valvular disease, tamponade, copulmonale would raise the JVP. Occasionally the JVP can be raised without its normal waveform. It loses the pulsatility, and that can suggest something sinister such as FVC obstruction by potentially a respiratory tumour. Specific wave formalities. Remember that the A wave corresponds to atrial contraction and the X descent is atrial relaxation. Now in conditions such as atrial fibrillation, where the atria are not contracting, they're fibrillating, you lose the A wave as well as the X descent. A giant A wave would mean that the pressure during atrial contraction is increased. So anything that would force the atria to increase its pressure, for example, an outflow obstruction caused by tricuspid stenosis or pulmonary stenosis or advanced pulmonary hypertension, would result in giant A waves. You can also have cannon A waves, where you have sudden, very, very sharp, tall A waves. And that would be when there's atrial contraction against a closed tricuspid valve. So for example, if a patient had tricuspid atresia, for example, or the atria was contracting against a closed tricuspid valve, for example, in complete heart block, or ventricular ectopics against a closed tricuspid valve, where there's atrioventricular dissociation, that would result in cannon A waves. The X descent can be steep in tamponade or constrictive pericarditis, and the V wave, which responds to passive filling of the atrium, that would increase in any condition which would very quickly increase the volume in the right atrium. And a good example of that is tricuspid regurgitation, where as you have ventricular systole, there's a regurgitant jet which will very quickly fill the atrium from the right ventricle. And the Y descent can be abnormal in constrictive pericarditis as you lose the ventricular recoil. Now move on to the precordium. Start by a thorough inspection. Inspect for any signs of scars. This may be from heart surgery, from pleural drains, there may be a pacemaker scar, or they may have more advanced scars such as a clamshell incision, and they may have any obvious defects or deformities or visible pulsations, and a good thorough inspection should pick up these various features. Some of the scars that you may note, you can see in the first image a midline stenotomy scar, so you have a scar, and you also notice two horizontal satellite scars at the inferior border of the midline stenotomy scar. This is used for the post-operative drains. Whenever you see any major cardiothoracic scar, also assess the neck for a tracheostomy scar, as well as over the lateral part of the neck looking for central line scars, which may suggest that the patient had a prolonged recovery and an intensive care stay following their surgery. The second image represents an anterior thoracotomy or a submammary scar. This can be used for pericardial surgery, minimally invasive cardiac surgery, mitral valve commissurotomy, as well as some respiratory biopsies surgery as well. The third image shows a clamshell incision, or a bilateral subpectoral scar, and this can be used for a double lung or a double lung and heart transplant. And you can see in the fourth image a subclavicular scar. This can be on the right side or the left side, and that can be used for a pacemaker or an ICD insertion. Move on from inspection to palpation. Palpate the apex beat. The apex beat is usually found in the fifth intercostal space, left midclavicular line, and it can be displaced in hypertrophic states or on the right-hand side in conditions where you have dextrocardia. Heaves and thrills. A heave is a precordial impulse, so as a result of hypertrophy or increased cardiac muscle, you can feel the heart against your hand, and that's a heave. Whereas a thrill is a palpable murmur, so when you can feel the aberrant jet and the turbulent blood flow through the valve, that's known as a thrill. Move on to auscultation. The aortic valve is heard in the second intercostal space at the right sternal edge. The pulmonary valve is at the left sternal edge in this position. The tricuspid valve is found at the fourth intercostal space, or is auscultated at the fourth intercostal space, left sternal edge. And the mitral valve is auscultated at the fifth intercostal space, midclavicular line. Remember that you can increase left-sided murmurs in expiration and right-sided murmurs in inspiration. You can accentuate aortic and pulmonary murmurs by asking the patient to lean forward, and mitral murmurs by asking the patient to lean laterally. And it's important to auscultate the carotids for any signs of radiation, particularly of aortic stenosis, and to auscultate the axilla for signs of radiation of mitral regurgitation. Once you've auscultated the heart, auscultate the bases of the lungs, trying to discern whether there's any signs of crepitations suggestive of pulmonary edema. Now let's just talk about the heart sounds. Heart sound 1 arises from the closure of the mitral and the tricuspid valve, and heart sound 2 arises from the closure of the aortic and pulmonary valve. S1, the mitral and tricuspid, can be loud in tachycardia, quiet in bradycardia, and variable in atrial fibrillation. The second heart sound is denoted A2P2, and that can be quiet in tamponade or aortic valve disease, but can be loud. Now, the aortic component is usually loud in systemic hypertension, and the pulmonary component is usually loud in pulmonary hypertension. You can also appreciate a third and fourth heart sounds in some patients. A third heart sound may be physiological in young patients or in adults or in septicemia or fever or in left ventricular failure. And that usually occurs early in ventricular filling and can represent the tensing of the chordae tendineae and the atrioventricular ring, which is a connective tissue supporting the AV valves. A fourth heart sound is pathological and associated with left ventricular failure. S4 is caused by the vibration of the ventricular wall during atrial contraction and usually associated with a stiffened ventricle in patients with ventricular hypertrophy or in elderly patients. A note on splitting. This, when we talk about splitting of the second heart sound, remember that the left heart has higher pressures, more myocardial tissue, and consequently more electrical tissue, which means that there's a quicker closure, slightly quicker closure of the left-hand side. So the aortic sound precedes the pulmonary sound, and that's why S2 is denoted A2, P2. But any condition that will delay the electrical activity or will delay the ejection of blood from the left-hand side will result in a widening or splitting of those sounds. And if the delay is so severe that the pulmonary component precedes the aortic component, that's known as a reverse split. And you would see reverse splitting in aortic stenosis, particularly advanced stenosis, where it's taking a long time to eject the blood through the aorta, and by that time the pulmonary valve is closed, or in left bundle branch block, where the electrical activity is delayed to the left-hand side of the heart. You can also see splitting in other conditions such as right bundle branch block, which results in wide splitting, or in a ventricular septal defect. Fixed splitting is characteristic of atrial septal defects, and that's because when you have a septal defect in the atria, inspiration produces no net pressure change, and as a result of that, S2 is fixed split. A note on accentuating murmurs. In general, anything that will increase blood flow through a valve will increase the turbulence and consequently increase blood flow. So raising the patient's legs or squatting increases the venous return to the heart, increases the cardiac preload, and accentuates murmurs. There are two exceptions, Hockham and mitral valve prolapse. If you increase blood flow to these two conditions, the murmur reduces. That's because if you imagine a hypertrophic septum, increasing blood flow to that chamber pushes that hypertrophic septum back into a normal anatomical or relatively normal anatomical position and abates the murmur. Similarly, with mitral valve prolapse, increasing the blood flow to the chamber pushes the prolapsed mitral valve back into its normal anatomical or relatively normal anatomical position, abating the murmur. Also note that increasing afterload increases regurgitant murmurs. Now, afterload is a pressure that the heart must work against to eject blood. So if you have increased backflow pressures, any regurgitant murmurs will increase in their intensity. So hand grip maneuvers increase afterload, and this would accentuate the murmurs of aortic regurgitation, mitral regurgitation, tricuspid regurgitation, pulmonary regurgitation. But they will soften the murmurs of mitral valve prolapse and Hockham, again because there's increased back pressure causing the septum to normalize or the prolapsed valve to assume its relatively normal anatomical position. We mentioned that we also auscultate the lung bases, and that's particularly to look for signs of pulmonary edema. If crepitations are present, you can ask the patient to cough. If those crepitations change or clear, that suggests that the crepitations may have arisen from a pneumonia or a consolidated area of the lung which is cleared with coughing, but if there's fluid there, those crepitations will persist. Move on to examine the limbs, particularly the legs, looking for signs of any scars. If there's any venous graft used in a coronary artery bypass graft, particularly relevant if you've seen a midline stenotomy scar, but sometimes those scars can be found in the arms. So it's important to inspect all of the limbs. Be aware that sometimes with a midline stenotomy scar, they may not have peripheral harvesting scars and an internal mammary graft may have been used. And then palpate the limbs, particularly starting with the legs, looking for signs of edema. If there is edema, quantify where it is, starting off with the feet, pedal edema, ankle edema, mid-shins, knees, thighs. If there are male, assess the scrotum, abdomen, thorax, all the way up to periorbital edema. And you can also offer to examine the peripheral pulses. This will then lead you to completing the examination, so thank the patient, make them comfortable, and offer to perform further clinical examinations, to record an ECG, to dipstick the urine looking for any signs of diabetes or hypertension, which could manifest as end organ damage with proteinuria, hematuria, or glycosuria, perform a blood capillary glucose, offer fundoscopy if not done so before, wash your hands, present the case succinctly to the examiner, offer differentials, and suggest a pertinent investigation and management plan. Thank you for attending this Medicine Masterclass.